Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing quite well. Thanks, Katie.
Dr. Robert Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines and our lone US COVID statistic through today, August 22nd. We invite you to submit any questions you have down below or via our social media linked in the description. Starting with our abbreviated COVID statistic, average COVID deaths per day in the last reported week were 88 daily. The same week in 2023, we saw 96. Dr. Murphy, your reactions to those numbers?
Yeah, so the death rate increasing is no surprise. If you just remember, just a few short weeks ago, it was down in the lower 20s per day. I mean, it's still bad, but it's 4 times higher now. And the other weird thing is that the daily rate is almost the same as it was in 2023. So that's rather telling because it means that we're kind of hitting this plateau where things are pretty much not going to change that much over time, and this may be what we have to live with. This is all due to these Omicron variants, the KP3 and KP2s, and the new vaccines are being designed against those variants that are circulating right now. And the only way we really know, other than the fact that everybody knows somebody who has COVID now, including members of our own department here, that the wastewater surveillance system is about the only way we know what's going on. So it's at very high levels right now in the Western and Southern US, and it's at, quote, high levels in the Midwest and Northeast. So just lots of people.
Lots of people. Mm-hmm.
Lots of people.
Now, you mentioned those COVID vaccines and what variants they're targeting, but there was some big news regarding them this week. Can you tell us any updates and what that buzz is about?
Well, the FDA is most likely going to approve the new vaccine, which is geared, like I mentioned, geared toward these Omicron variants that are floating around now, this week. When that happens, Pfizer, Moderna, and Novavax are ready to go releasing their vaccines. Now, the Pfizer and Moderna are mRNA vaccines, and those are geared toward the KP2 variant, which is what's one of the circulating ones now. The Novavax vaccine is geared toward the JN1, which is kind of one level up from those variants. The technology in the Novavax one, they couldn't change it fast enough and had already started production of the JN1. So there's a slight difference, not only in manufacturing, but in the direction of the vaccine. They both should work. They're both working better than what is available now, which is very much unrelated to what is circulating these days. So we should hear something very soon this week. Getting this thing approved. And then once that happens, the vaccines will be released into the system really pretty much right away. And they can be given with the new flu shots, which are also available. So we had talked about this before, but there appears to be an advantage of giving the flu shot and the new COVID shot or any COVID shot on the same day. And that for whatever reason, the flu shot actually enhances the effect of the COVID shot. The reverse is not true. The COVID vaccine does not change, good or bad, the effect of the flu vaccine. But anyhow, You can take them on the same day. It's approved for that, and then you can get it all out of the way, and you'll be prepared for the winter wave, because this will go down, and then it will come back again in the winter if it's just like any other year. So that's what's happening.
Now, sticking with COVID, there was a new study that looked into how loss of smell from COVID infection can have an effect on your brain overall. Pretty shocking stuff. Can you please break down the findings?
Yeah, this is a relatively small study of 100 participants from Chile. 73 who had prior mild COVID and 27 who had never contracted the virus. And they looked at a whole bunch of tests, neurologic tests, but also MRI, magnetic resonance imaging of the brain, very sensitive way to look at your brain. And they were very surprised to see that those people who had had loss of smell, which, remember now, it's pretty common in COVID, had all sorts of different structural issues in the brain, in the lateral prefrontal, median frontal, and left temporal parietal regions of the brain. These are just geographic regions of the brain. But these are like physical findings. And also loss of white matter of the brain. The brain has white and gray matter, and the loss of white matter and reduced cortical thickness also observed in this group. So you don't have to be a neuroradiologist to understand that something structurally is going on in the brain. And what does this mean? Is this just a marker of other things to come, or are these structural problems, damaging now, or is this a precursor to something later? This we don't know, but it's of course being studied. These findings are really very disturbing. It's not good having this virus. It's the same thing with HIV. When a person gets HIV, their immune system is never back to baseline. It can improve significantly and people have less problems, but it never goes back to completely to normal, or very rarely anyway. This is a disturbing finding, and it's something that is going to be looked at more closely and followed more closely.
And something we will keep up to date on as best we can as more information comes out. However, switching gears, last week we reported on the announcement of the global health emergency of Mpox outbreaks in Africa. Have any other global cases of the specific clade been identified, and how has the global response changed?
Yeah, so just to back up just 1 second. So, Mpox, formerly called monkeypox, was endemic in primarily Central Africa and Congo for many years. And the clade, or the type of the virus, was type 1. They've had 14,000 of those cases with over 500 deaths, and over 96% of the global total came from the Congo. What happened is they found a subclade of that called 1B. And that has been responsible for the big increase in the number of cases and deaths this year. The cases are up 160%, 19% increase in the number of deaths. And the number of countries in Africa went from 1 to 13. So, and now what's being reported is that Sweden, with a person who came back from Africa, has this 1B clade. So the 1B clade has jumped out. The big epidemic we had 2 years ago in all the men who have sex with other men, that was clade 2. That is less lethal, less than 1% mortality rate with that. Very easy to spread sexually. But now we have 1B out there. It's in Sweden, and there was another case reported this morning in Thailand, again from a visitor to Thailand who had been in Africa, then was transited in the Mideast, and then went to Thailand. So there's 2 cases. There was another case reported from Pakistan, but that turned out to be a clade 2. Anyway, what does this mean? It means that this pretty nasty new one, 1B, which has a mortality rate of about 4%, has jumped to multiple countries in Africa and has also been reported in Sweden and now Thailand. And, this is not a good thing to be happening because it's 4 times more lethal, at least, than the monkeypox that was spreading around 2 years ago, which is, we still are having those cases. So anyhow, the WHO earlier or last week declared an official emergency, and that opened the floodgates for various international agencies and countries to jump in and try to help stop this thing. And that included Gavi, which is the organization that works with UNICEF and other international groups to deliver all sorts of vaccines, committed $500 million to spend on getting these vaccine shots into countries in Africa to stop this spread, because they know where it's really coming from. So that's from their first response fund. But the many other players are involved here. The United States donated 50,000 doses of vaccine from its stockpile. There were 100,000 doses donated by the country of France, and the Bavaria Nordique vaccine, over 170,000 doses were purchased by the European Commission. And another 50,000, I think 40 or 50,000 were donated by the company. So it's all like moving, getting things in motion. So that's pretty quick. So this is like a good response. I mean, you can always say it could have been earlier. Well, okay, it could have been a week earlier. But anyway, other companies like Emergent Biosolutions this week said that it would donate 50,000 doses of its smallpox vaccine, which also works. It's a live attenuated vaccine, so it has more side effects associated with it, but it is very effective. And also Roche, the Swiss company, their diagnostics division, is partnering with the governments and healthcare providers with the testing for monkeypox throughout the region. So things are really switched into pretty high gear in the last week with Mpox.
Mm-hmm. And that's very good news that we are finally seeing this massive response.
Yeah.
But here in the US, we need a response of a different kind. We have been having more measles cases this year than usual. Can you update us on how many cases there are, where they're popping up right now, and why there's more this year than in the past?
Well, measles is highly, highly contagious, and it can kill people. Measles encephalitis can cause death, but it's more likely to cause severe enough illness to be hospitalized. And of course, if you're hospitalized or you have active measles, you're in the emergency room, you can spread it to other people. So anyway, the big problem mostly is that it results in a lot of hospitalizations and a few deaths. Now, the number of cases are up, and they're up because the herd immunity required for measles to be kept at bay is 95% or greater. So as soon as you drop below 95%, you'll start seeing outbreaks. And that's exactly what's happening here. And in these cases in Georgia, reported their 5th case. The person was not vaccinated. In Oregon, the 30 cases, none of them were vaccinated. Most of these are children, but some are even in adults that are not vaccinated. Over 80% of all the cases, there were 219 altogether in the United States so far this year, 87% were unvaccinated or with unknown vaccine status. And 45% of those patients have been hospitalized. So that's the whole deal here with measles. It's a totally preventable infection that can cause serious illness requiring hospitalization in adults or children. And in rare cases, it can cause death.
Something to look out for, that MMR vaccination. If you're unknown status, maybe look into it. It can be dangerous.
Yeah, if you
But
know, get another shot. I mean, it's not going to hurt you.
Now, our last topic today is cholera, something we haven't talked about too often, but there were some startling numbers released by the WHO recently. Can you tell us what was found?
Yeah, so cholera is a waterborne disease. It's usually associated with interruption or destruction of water supplies, safe water supplies. Global warming has something to do with populations that are moving around from natural disasters or political disasters. And the number of cases is way up. In July, 17 countries reported nearly 52,000 cases, including 223 deaths. The Eastern Mediterranean region was hit the worst. There is an oral cholera vaccine, and 105 million doses was requested by 18 countries since January of 2023. Which was nearly double the 55 million doses that were produced during that period. So they're asking for more of the vaccine than actually exists. And so this is just another problem out there. It's an oral vaccine, very easy to take, and it's very unfortunate.
Very unfortunate. And on that note, we're going to have to close up for today. Thank you so much, Dr. Murphy, for your time and your expertise, breaking down the articles and all of the relevant research for us. It's much appreciated.
Well, great. Thank you, Katie. Have a great weekend.
Thank you. And thank you all for joining us for this week's episode of the Ask Dr. Murphy series. We hope to see you again next week. And if you have any questions or suggested topics you'd like to see, please feel free to leave them below in a comment or at any of our social media linked in the description. Have a great weekend.